So we've certainly had T-DM1 available for patients with metastatic HER2 positive disease now for several years and have seen that it is generally a well-tolerated therapy. We do know that some of the common side effects that we see from it do include lowering of platelets, elevation of transaminases, elevation of bilirubin, and some peripheral neuropathy. And so while it is a very targeted delivery of chemotherapy, there are certainly some side effects. We have also used T-DM1 in the early disease setting on several clinical trials. So for example, we had the ATTEMPT trial, which looked at T-DM1 for a year in patients with stage 1 HER2 positive disease. And while data hasn't yet been reported from this study, I think anecdotally we all saw that there were patients who did have to discontinue T-DM1 early due to side effects, due to some of these side effects that we just discussed. And we've also seen something similar from the adjuvant Caitlin study when we were utilizing that in patients in the early disease setting. And so I think the data from Catherine sort of showed us how well tolerated T-DM1 is, in a sense that most people did very well with 14 cycles of T-DM1. However, it is important to realize that about 18% of patients on Catherine did require early discontinuation, so they were not able to get all 14 cycles in of the T-DM1. And the reasons for these discontinuations were different. So it wasn't just one common reason that people were stopping, but instead we saw that some of the reasons were due to thrombocytopenia, elevated bilirubin, elevated transaminases, and neurotoxicity. And so it is important for clinicians to be aware of these side effects because they do occur. In this particular case, we did see that after being on T-DM1, our patient did start to experience neuropathy. And so that is something that can occur with T-DM1. However, I do think it is also possible to manage patients with neuropathy on T-DM1. So generally speaking, our approach has been to hold T-DM1 at the onset of grade 2 or higher neuropathy and wait for resolution to grade 1. And once it is improved, we usually restart with dose modification, so one level of a dose reduction. And often patients are able then to continue quite well. I think the neuropathy, generally speaking, from T-DM1 is usually mild. In Catherine, it was only about 1.5% of patients who experienced grade 3 neuropathy, so it's not very common, but again can be managed with treatment holds and dose modification. Other toxicities that can occur with T-DM1 that I think you just have to be aware of are certainly the low platelets. So we do see low platelets in about 30% of patients getting T-DM1. So again, it is pretty common. The rate of grade 3 thrombocytopenia is about 6%, so more common, for example, than grade 3 neuropathy would be on T-DM1. So we are seeing this. It is a reason to hold therapy in patients and then potentially dose modify when platelets resolve and come back to grade 1 or better. We do tend to see this dip in platelets usually early on. So if you give the dose of T-DM1, usually 7 to 10 days after administration of the T-DM1 is when you see them nadir, and then they tend to come back up. Usually they've improved in time for your next dose of therapy. But again, in about 30% of patients, you are seeing some level of thrombocytopenia at time of need to start the next cycle. I think the other thing to keep in mind is this issue with transaminases and bilirubin. And so it is, again, important to be aware that about 30% of patients actually do get elevated transaminases. And so, when they are grade 3, I've generally been holding T-DM1 and then, again, dose modifying. But as you can see, again, 18% of patients aren't able to complete all 14 doses of T-DM1, and certainly that can happen. I think if physicians run into this problem where they've tried dose holds, dose modifications, and they're still seeing challenges with grade 3 or higher toxicity, that is a point where a transition to trastuzumab is quite reasonable. So it is important to realize that on Catherine, if patients did have early discontinuation, they were allowed to then go on to trastuzumab monotherapy and complete the year of treatment with trastuzumab. And so that is very reasonable. And despite, again, 18% of patients having early discontinuation from adverse events, you're still seeing this 50% improvement in invasive disease-free survival. So again, I think using T-DM1 was critical for these patients, even if they had to stop early. For me, I think one of the biggest lessons that Catherine taught us is that we can change patients' outcomes by looking at their response to preoperative treatment. And so to me, that's a huge practice-changing phenomenon. So while we knew that having residual disease was associated with worse outcome, we really couldn't do anything about it. We didn't have a way of tailoring therapy to improve patients' outcomes. But now we have a way to change that. So while, again, that path previously had shown that those patients who failed to achieve a path CR have worse long-term outcomes, we've now dramatically changed their Kaplan-Meier curve. So now those patients are doing much better. And so, my hope is that there is still room to improve. I think one thing that was interesting from Catherine is there wasn't a difference in rates of CNS recurrence. So there was the same number of CNS recurrences in patients getting T-DM1 compared to trastuzumab. So I still think there is room to improve, that we do need to think about how we can lower rates of CNS recurrence. And there are also additional agents that I think could be studied in this space. There are newer antibody drug conjugates, there are new tyrosine kinase inhibitors. And so I do think while we've dramatically improved outcomes, I think there's still hope that we can do even better.